very excited on behalf of my co-chair and colleague Lisa Pickering, myself, to welcome you to what's promised to be a very exciting and perhaps controversial debate on a number of topics, including the choice of first-line therapy for intermediate and high-risk RCC, followed by the choice of therapy for those favourable risk patients. And lastly, we'll have a debate on what should be the comparator arm in future first-line studies. But I hope you can hold on to your excitement for those debates because, importantly, we're going to hear from Salvo La Rosa about some KCA updates. Thank you, Salvo.
All right. Thank you, Samra. And thank you to the organizing committee for putting together a very exciting program. And I think the morning has been very, very interesting topics, very relevant. So what I'm doing in the next 10 minutes is to give you some updates and put you up to speed on what's going on at Kidney Cancer Association, what we're trying to do. And with that, I hope that by the end of my presentation, short, you will have a better understanding of what resources we have created for patients and for healthcare providers, and also learn about some of the KCA data-driven programs. This is brand new programs that we are pulling together, and opportunity for collaboration. So we're not doing this in isolation, but we need your guidance. We need scientists, medical oncologists, everybody, to work together and use this opportunity to have access to this data that we now have. So a few highlights on the program. So we'll touch about patient program, as I said, the clinical trial finder, some of the tools that we developed this year, like the patient navigator, the virtual patient symposium, other supports that we have available for patients. Then I will talk a little about other collaborations with other organizations in the field, especially our affiliate programs and other collaboration with other, let's say, cancer agnostic organizations that help whole patients. And then I'll touch shortly on the research programs. So how we envision participation of patients in research, how we are, incentivizing that, and new partnership there I'm going to announce today. So this is just a snapshot of the 4 pillars that the Kidney Cancer Association is. What we're doing is supporting patients. You see a lot of programs that are there. I just want to focus on the new stuff that we launched since we updated you in Europe last year. So there are quite a few things going on. I will touch on some of them. We have building a pipeline of research programs. And we're also, creating new resources to educate HCPs and educate patients. And we're also trying to advocate and partner with other organizations to be more vocal, more powerful, more impactful to, gain what needs for patients, especially with the government. So for patient resources, the first tool I want to touch on is the Clinical Trial Finder. This is something that we created on our website. It doesn't not only, let's say, pull data from clinicaltrial.gov and simplify the language and make sure that patients find the information they're looking for, but it's just version number 1, version v.1. What we want to do is to integrate this into experience that patients have, into, let's say, discussion, later breakthrough that this trial is mentioning at conferences, and make everything connected. So when patients look for a trial and they look for their specific subtype, for instance, they found the trial, but they find a lot of other resources that are connected with the trial. So it's not just, information on what is it, but also how it behaves and how it evolves with time. And those trials, they're, of course, very old. Some of them, they're still reporting data after 10 years they started. So it's a way to give back to patients, I think, information in a centralized way. So this is the vision for the future. The other resource that we just launched is a treatment center finder. This tool is only available in the US for now. We hope we can build similar tool in Europe identifying all of the treatment finders that are providing, care for patients with kidney cancer. We base this tool on data that we got from Komodo Health. Komodo Health is an organization that put together databases based on ICD-10 codes. So all of those organizations that bill for kidney cancer, they're showing up there. And we know that, there are some institutions that have better volume. So we try to map all of those that are, with certain specialty, by region. So patients come to the website, they can see, for instance, in their state, what are the available, providers. And as I said, again, version 1.1, you see there is a little button where you can look at the view, the center details. That is currently empty, but then the future we want to integrate with specific data that we receive from that institution, for instance, on what they offer and what kind of specialty, what kind of subtypes they're specialized in, and for instance, how many patients they see a year. So the patients can make their own decision if they want to travel 100 miles more or they want to go to their local center, depending on, the idea they get about that center, what they can actually find. Very important one, and I think one of the most powerful education that we delivered last year, the most attended one, was the Virtual Patient Symposium. This is something that you can point your patients to. We are trying to work with medical professionals, simplifying the concepts and demystifying some of the things that happen during a patient visit, or when, for instance, patients receive their pathology report, how to interpret, what are the information there, what that means. So they can understand better, they can feel like they understand what is written in there. So you can see there on the right the program at glance that we had in 2023. It was very, very successful. We also talked about what happened in those tumor boards, what happens when your case is being discussed, what that means, and they saw the dynamics, and it was very well explained and received. So we got excellent feedback on that. So we already have a date for 2024, September 24. So this is going to be highly advertised on our website. So if you want to have your patients tuned in, that would be fantastic, because this resource is highly educational. And it's going to be available on demand also on our website. We're also moving towards more in-person symposium, not only virtual. We're trying after the pandemic to go back to those centers that organize for families that are living nearby, and really be there together with them, so that we can create more strong bonds and listen to them and involve them in person. Other webinars that we're organizing also in collaboration, for instance, with the ABTA, the American Tumor, the Brain Tumor Association. For instance, we are creating webinars on specific topics, and with ABTA, we're planning one on brain metastasis derived from kidney cancer. So it's coming up this year. And there are other online resources like the podcast that has been very successful. We dropped the first 6 episodes, and it was very well received, made by patients for patients. We have a toolkit, we do infographics, video library, and I want also stress the blogs that we're trying to translate amazing findings that we see in this community and explain what that means to patients. So here is an example for exercise and sickle cell trait based on RMC, of course, and the found that there is a specific risk factor that they need to know, and we wrote this in collaboration with the Sickle Cell Association. Okay, moving along with other programs that we're doing with other organizations. We partnered and we created an affiliate program. Affiliate doesn't mean that they're only working with us. We are affiliate of them too. So we are reciprocal affiliates, if you want, with other foundations and organizations that are looking forward to serve their patient population. And you see the names there on screen. So 6 of them are related to kidney cancer and different, subtypes. And the other organizations that are instead, looking at general or let's say more distant related topics, but always relevant. And you see, I don't want to talk to all of them, but with each one of them, we are creating a program that can serve our mission and can serve their missions in serving, the common patient we have. Okay, now switching gear and talking about some of the research program we're pulling together. Here in these slides, I want to highlight how we are envisioning patients' participation in research and what we actually were able to offer them. So today, if a patient comes to me and say, oh, I want to participate in research, there are 2 options. They can either, donate their tissue, and this is an option that we work with a recent collaboration with the Rare Cancer Research Foundation and their program called pattern.org. They basically allow patients to donate their excess fresh tumor tissue when they undergo surgery. They take care of, let's say, all of the paperwork with that institution. They have shipping kits, and they can freeze on the operating room and ship to the lab that actually needs that, make a request for tissue. This could be for many different reasons, for creating cell lines, for sequencing, for everything, but the patient is at the center, and they decide which of those, let's say, labs they want to give their tissue to. So that is one option, and the other one is data. So we made a very new collaboration we signed this year with IKCSEU24. And IKCSEU24 is a technological company that is able to organize health records, so medical health records, based on their technology, algorithm, AI that nowadays is everywhere. They are actually running an Excelsior trial, which is a clinical trials with an NCT number. And every patient can basically consent to the trial, and they give access to their data. And what IKCSEU24 does is 2 things. They basically give access to the patients, to their data in a highly organized manner that they can basically use for their own purpose, as portability, as organizations, and so forth. And they also put that patients in a larger cohort of cancer patients, and they already have over 100,000 on their portfolio, where they basically create de-identified data sets that can be used by researchers. So KCA being part of the study, we have access to that data. And we are willing to work with all of you who have questions that we can interrogate this database together. So we're going to do that to understand a few things. But there are a lot you can actually infer from this type of data. I want to give you just a snapshot of one case. And this is on their website just to highlight, the potentiality. You see, for instance, in this patient's case, there is at some point regular visit just for family medicine. And then at some point in 2016, something happened. And you see oncology encounters. Each dot is an encounter. It's just, how they basically encounter healthcare. And you see happening some, radiology and radiation, and then they have surgery, and then there is a period where it's quiet, and then, it gets back busy with oncology on high volume. So this gives you an idea of what a timeline for that patient is. Imagine having thousands of those that you can actually infer quite a lot from that. So we're going to have access to this. It's not just encounters, but for each encounters, you may have lab work. For each time point, you may have whatever, it came out of that encounter. And there's a lot of data to mine, basically. And the other collaboration that I just want to announce here, we just signed. We haven't yet put a press release, but it's going to drop in the next weeks, is with Tempus. Tempus is a clinical genomic company, precision medicine that use AI. And we're very excited about this collaboration because it's going to fund a postdoc fellow collaborative programs called. So Tempus has a very impressive state-of-the-art database, and it's probably the biggest that is out there. I mean, the numbers are really staggering. Imagine it's 25 times the size of the Cancer Genome Atlas in terms of, petabytes, and has 6 million records. We hope that funding this postdoc that will have a Tempus badge So we'll have access to all of the resources at Tempus. They will work on advancing kidney cancer research. So it's going to serve both organizations. So it's going to serve KCA because we want to advance and interrogate this database for what we need and what this community needs to know. And also will advance Tempus because they're interested in building fundamental scientific tools and showcase the scientific value of their data, of course. So how this is going to work is going to be projects that will be driven, supervised by kidney cancer experts. As you see here, we have the first two experts that are, already, putting together some of those programs. So Pavlo Smysal and Elizabeth Hensky. And then they will be housed at the cancer genomic unit at Tempus. So there are some of the initial projects. We'll explore predictive biomarkers of response, toxicity, improve algorithms for histological subtype diagnosis, and comparative TME analysis across primary and metastatic sites. Those are the initial ideas, but you see there is a gray, empty phase, which could be yours. So if you have ideas of how to use this Tempus database, please reach out. And we can work together. We have the time. This is a collaboration that is going to last for at least 2-3 years. So I hope you learned what we are doing. You are excited, as I am, of the future and what this data will bring us, hopefully. So you can also use our programs for your patient population, just to know that those exist and there is material that you can use and it's ready to go. Patients can participate in research by donating tissue and data if they want. And we are really looking forward to hear from you for your research and collaborate across, multidisciplinary collaborations. So thank you so much.
Salvo, thank you very much indeed for showing us the work that KCA is doing, not just facilitating this, if I might say, fantastic meeting, but also in supporting patients and enabling research. Salvo, thank you. So now we're going to move to the second part of this session. So we, as Samra has described, we are setting this up as 3 debates. So we'll hear each debate. There'll be a short Q&A or discussion after each of them. So the Q&A and for the panel will happen after each debate rather than running the whole way through. So for the first of those, we're going to hear about options for treating people with advanced renal cell carcinoma in the intermediate and poor risk. So I'm first welcoming Laurence Albigez, who's going to talk to us about why we should all be using IO-TKI combinations for these patients. Laurence, thank you.
Thank you very much. Well, first, I want to thank the organizing committee for the pleasure and honor to do this debate with Manuela. I really want to express how much she's been both an inspirational to many of us, but also a role model to me. And I'm very happy about the award she received today. So my task in this debate is to convince you that we should go for IO-TKI across patients with IMDC intermediate and poor. Currently, we have 3 regimens that are approved by both FDA and EMA, and that has demonstrated both a strong initial response, but also overall survival benefit. So I'm just going to use 5 letters. A as an advantage in short-term endpoint, meaning that we do know across the 3 trials, Axi-Pembro, Cabo-Nivo, and Len-Pembro, that this strategy is allowing to prevent early disease progression. And we will see why it is important. We also know that this strategy against IO-IO strategy is actually doing better job in terms of progression-free survival, how much time we can control our patient before further disease progression. And ultimately, that is inducing a strong, deep response below the 50-60%, meaning 6-7 out of 10 patients will have significant tumor shrinkage. And why is this relevant? We heard earlier this morning that patients that have IMDC intermediate and poor may be symptomatic. They can have poor performance status. They can have biological poor risk features, that's the definition of the IMDC criteria. And they can have upfront metastatic disease that does require systemic therapy right now. So what I want is this initial response to prevent disease progression at this time of the disease development. How does that translate into real-world practice? Well, there has been data set, and we heard from Danny Heng himself from the IMDC, that IO-TKI, in the very first analysis that IMDC was able to conduct when they had gathered enough case, was clearly inducing this strong response rate in the range of above 50% both in intermediate and poor when you pull both together when compared to IO-IO strategy. And that translates to a longer treatment duration and less need of getting to our subsequent line therapy when compared to IO-IO. This is true across different data sets. That's an effort that Camillo Porta led throughout Italy. It's fewer number of patients, but the bottom line is the same in intermediate patients. Here again, IO-TKI, although it is retrospective, is doing a better job as IO-IO. The B is that we have a consistent benefit in overall survival across the 3 studies within the IMDC intermediate and poor, the hazard ratio being somewhere between 0.73 and 0.76, including the most recent updates when we look at IMDC intermediate and poor. The C is that this is consistent. The benefit in overall survival is consistent. It means that we have treated now thousands of patients, and this is a meta-analysis that was led by the FDA that has been published, with this very consistent hazard ratio, both in terms of overall survival and PFS in the IMDC intermediate and poor. Lastly, it's doable. We heard this morning that in terms of quality of life, looking at Cabo-Nivo, we are able to handle this in the long run. And there are some treatment-free survival piece that we believe is very important for IO-IO. We also have data now in the IO-TKI that was gathered by FDA. What we do know is that patients are able to stay under TKI in the long run in combination. So we have learned to manage these patients and the combination in the long run beyond the 2-year mark when exposing our patient to TKI. I'm going to finish on the question of evidence. Why is that? It's because as of now, we don't have head-to-head comparison of one approach versus the other one. CARE1 is an EU-funded trial funded by the Mission Cancer Horizon. That is a clinical trial that is randomizing patients between the 2 strategies, IO-IO versus IO-TKI, with 2 different assumptions. That in PD-L1 positive patients, IO-IO will actually be superior to IO-TKI in overall survival, and that in PD-L1 negative, according to the BMS assay, meaning 3 patients out of 4, 75% of our patients, IO-TKI would actually be better than IO-IO. And this trial is now a reality because it has been approved, and we have started enrolling patients. The first 2 patients has been consented. We'll enroll 1,200 patients across 100 sites in 8 countries in Europe. So I believe that at the end of the day, we'll find an answer to how we can select with a pragmatic approach and manualize part of this trial. So we will make the answer to our debate together in a few years. Thank you very much for your attention.
So Laurence, thank you. So now we look forward to hearing from Manuela why the opposite strategy she believes is going to be the winning strategy in the CARE1 trial. And on that note, I would really like to congratulate Laurence as PI and also Manuela and the other collaborators for having had that trial funded and started last week. But now we wait to hear why IO-IO is going to be the winning strategy.
Thank you, Lisa. Ladies and gentlemen, so my task is to discuss IO doublets. So what do all these first-line strategies have in common? PD-1 inhibition is the common denominator for all successful first-line strategies. And we are debating the type of add-on, and this remains a challenge when choosing treatment. How to choose the perfect add-on when so many questions, however, remain unanswered? Is the addition of ipilimumab important at all? We don't know yet. CA209 trial 8Y8 will show, but we don't have the data yet. However, we know from melanoma that ipilimumab is important as an add-on. Is the upfront addition of ipi important? Ipi salvage trials are clearly disappointing, so yes. Is the addition of a TKI important, or can the immune checkpoint inhibitor do the job alone? Here we only have data from IO doublets combined with a TKI, not from TKI combined with a checkpoint inhibitor. Is the upfront addition of the TKI important? This is unknown. There is a study pedigree, may give us some ideas about this, but it's addressing the maintenance phase rather than upfront single agent. Can biomarkers help? They may, but they're not clinically available. They don't include contemporary treatments and relate to and or are conclusive for response PFS and not OS. So what is important for the patient, Dina Battle has shown it, the chance of eliminating all disease and the durability of that the treatment works. Which treatment comes closer to the patient's expectations? Well, the chance of achieving objective response, CR, is high with IO-TKI, as Laurence perfectly pointed out. But the duration of response in intermediate poor-risk patients, from my point of view, there are too many question marks. We don't know from Axi-Pembro, we don't know from Len-Pem, we know from Cabo-Nivo, it's 23 months, while it is 82 months for Nivo-Ipi. The durability of response is unparalleled with an IO doublet in intermediate poor-risk patient. So given the exceptional long-term benefit, Nivo-Ipi should be used in intermediate and poor-risk patients whenever there is no urgent need to shrink. Laurence had clearly pointed out that primary progression is more common with IO doublets than IO-TKI. But when there is no urgency, Nivo-Ipi is highly welcome. I also would use it in specific subgroups that have already been defined, such as sarcomatoid features, PD-L1 positive, and in subgroups that remain to be defined. And treatment beyond progression should be the standard strategy with IO doublets rather than the exception whenever clinically acceptable, because response PFS at first scan are completely useless. In many patients, up to 30% or more will eventually respond later. So not choosing Nivo-Ipi in first line is a missed opportunity for long-term benefit for this 82 months duration. Nivo-Ipi is less promising after failure of IO-based first-line treatment. In contrast, IO-TKIs were shown to be highly active in terms of efficacy after failure of an IO-based first-line treatment. These are the data from lenvatinib pembrolizumab in second line. So take-home message. Ipi-Nivo is underused in intermediate poor-risk patients, and this is a missed opportunity for long-term survival and exceptional duration of response. It should be used upfront because the chance to achieve something really big is in first line. In contrast, IO-TKI are also active after failure of IO-based first-line treatment. In patients with sarcomatoid tumors and in patients with PD-L1 positive tumors, and when time or need to shrink is not the #1 priority. Responders among intermediate poor-risk patients have a response duration of 82 months. Why are the response durations not shown for intermediate poor-risk with Len-Pem or with Axi-Pem? I'm still waiting for them to be shown. Nivo-Ipi will be used more often once better predictive tools are available in clinical practice. And I think it's only the lack of these biomarkers that make us choose IO-TKI more frequently. We are picking a treatment rather than really choosing or selecting a treatment. Objective response and PFS are useless in IO doublets. Better endpoints are needed, for example, time to next systemic treatment. Thank you very much.
Thank you. And so I would now like to open this to either fellow panel members or the audience. If you have any questions that you would like to raise for Laurence or Manuela. I can't see who it is. I'm sorry, my glasses are. Oh, so it is. Fire away.
I'm so small to be able to see. Actually, my question is, whenever we talk about and compare IO versus IO-TKI, we talk about the duration of the response. And we say duration of response is more longer with IO plus IO. But let's assume we started with 100 patients, is both group. Actually, the number under the risk, it's same. Even the percentage with IO is higher because at the beginning, response rate is around 40%. At other side, it's 70%. And of course, duration of response of 40% is better than duration of the response of the 70%. But at the end of the day, patients who live longer seems similar in both group. And I actually want to learn your comment about this. Thank you.
Thank you, Yüksel. I think you're raising a very important point. Duration of response is an endpoint that we are looking at in patients that are responding. And therefore, it's not, we're not looking at the same patient population as you stressed. So it is relevant because it means in a patient that is responding, the likelihood that it will last, but you stress the fact that the overall number that are able to achieve this may be lower in the IO strategy. And so that is a communicating tool. I think it's important, but that can't be used as the only endpoint, as you stressed.
So I wouldn't say it's the only endpoint, but I'm still wondering why we don't see this data from LenPem and AxiPem. What's the point in not showing them for the intermediate poor risk patient population? We only have got them for the ITT patient population. And sometimes, and we need to be aware of this, the TKI, when given after a while, can also lead to the to kind of a tumor cell selection of the more aggressive, leading to a more aggressive disease. So VEGF inhibition on the long run can also drive metastasis. So there might be a biologic reason why at the end of the day, maybe duration of an IO doublet response is longer.
So I don't think there are any other questions at the moment, so I have a question for you both. You have acknowledged by setting up the CARE1 study that there are some unanswered questions as to which of these doublets are better. So from an educational point of view for the audience, whilst it's of course always fun and entertaining to think that only one option is available and one is better, are there areas of consensus? So can I ask when you'd each agree perhaps to use IO-IO and each agree to use IO-TKI? So I'm going to flip it around and ask Laurence to start with. When would you always use IO-IO?
I would use IO-IO in a patient that doesn't have a lesion at risk, exactly as Manuela put on her slide. And because I'm aiming at this long-lasting response, I'm doing exactly what was stressed. I want to go for my IO doublet because I only have one shot at this. And so I'm clearly using it in a patient that doesn't have lesion at risk. On top of this, I'm paying attention to the knowledge of, is there any sarcomatoid component, which here again triggers my attention to IO-IO. Now, why in CARE1 we use PD-L1 as our stratification factor? Because we have data from 214 that the hazard ratio over sunitinib is actually higher and the highest in the PD-L1 positive, but also in the 9ER using the same assay that TKI-IO is doing better in the PD-L1 negative. And that was true in 214, but if you pay attention on the PD-L1 piece from the adjuvant Nivo-EP 914 study, this is exactly where we have a separation of the curve in these negative adjuvant trials. So that's the rationale for PD-L1.
Thank you, Laurence. So Manuela, I know, acknowledging that we don't have the results of CARE1 yet, in clinical practice now, when do you always use IO-TKI?
So I would definitely use this whenever there is a need to shrink, meaning either in a symptomatic patient or large tumor burden. I would also use it, for example, in patients who have signs of myeloid inflammation, neutrophilia, thrombocytosis. I would suggest that in a patient with myeloid inflammation, this could kind of give an idea that maybe the tumor microenvironment is also displaying a myeloid myeloid tumor microenvironment, and whenever we have inflammation that triggers interleukin 6 triggers myeloid-derived suppressor cells, and I wouldn't expect a pure IO-based treatment to work in the patient. Another idea is, for example, patients with pancreatic metastasis. Of course, you can discuss whether this could be a candidate for VEGF inhibition only. But there is at least retrospective data that VEGF is the backbone for pancreatic metastasis.
Thanks very much. Now it's time to move to the favorable risk setting. And we're fortunate to have two Spanish debaters, so I'm sure it's going to be intense and passionate. So I'd like to invite Cristina Suarez first, and the debate now is between VEGF TKI monotherapy and IO-containing regimen. Cristina, thanks.
Thanks, Samra. Thanks, Lisa. So yeah, we could do a discussion in Spanish. That would be much more appealing, I think. So yeah, I have to defend IO-containing therapy for patients with favorable risk and prognosis. So the learning objective is to learn pros and cons of the different options in first line. So I would like to make a disclaimer before starting my talk. In the absence of biomarkers that allow us to individualize treatments, whenever we use a doublet, we will overtreat in some patients, and whenever we use a TKI monotherapy, we will be undertreating some others. So in fact, it's a matter of choosing if you want to take the risk of overtreating patients or undertreating patients. Having said that, we know that there is a synergistic effect when we use a PD-1 or PD-L1 antibodies with a VEGF inhibitors. We know that VEGF enhances the mobilization and proliferation of regulatory T cells, enhances the release of immunosuppressive cytokines, activates myeloid-derived suppressor cells, inhibits dendritic cell maturation and antigen presentation, reduces the proliferation and activation of naive CD8 cells, and prevents antigen-activated CD8 cells from infiltrating the tumor tissue. So we could say that VEGF promotes immune escape at almost every step of the cancer immunity cycle. So with VEGF inhibitors, we reprogram this immunosuppressive tumor microenvironment into an immunostimulatory microenvironment. So the administration of PD-1 or PD-L1 antibodies under such conditions enhances the anti-tumor activity of T cells. So doing or using IO or VEGF and IO sequentially instead of combined, we could lose this or could miss this synergistic effect. I would like to keep in mind that the 4 trials were positive, the CheckMate 214, the CheckMate 9ER, the CLEAR trial, and the Keynote 426 trial were positive in overall survival for the ITT population, although we know that the CheckMate 214, the primary endpoint was in intermediate and poor risk patients, but they all showed a benefit in OS in the ITT population. It is true that no OS benefit has been seen until now in the favorable risk patients, but all the IO TKI trials showed a benefit in PFS with the combination as compared to sunitinib. In fact, and Logan's presented this paper just right now, the FDA carried out a pooled analysis of the 4 IO TKI trials, so included also a Javelin trial, and this pooled analysis displayed a benefit in progression-free survival for the combination of IO TKI versus sunitinib with a hazard ratio of 0.63. They didn't show any benefit in overall survival, but the authors conclude that this could change with longer follow-up. In addition to all this that have been said, I would like to remind that overall response rate was higher in the combination arm in the 3 IO TKI trials, in the Keynote 426, in the CheckMate 9ER, and the CLEAR trial, and complete responses were higher in the 4 trials with the combination as compared with sunitinib. And we know from post-hoc analysis, and we already knew in the TKI era, that there is a directly relationship between the shrinkage of the overall response rate to the outcomes and to the overall survival. Finally, we know that 7 clusters, 7 molecular subtypes have been described, and we know that in the favorable risk patients, there are a predominant cluster or predominant angiogenic profile. But as you can see here, many patients with favorable risk tumors will not have this angiogenic profile and will have mixed profiles that would not be covered if you use TKI monotherapy. So which patients would I treat or not with TKI-IO combinations or even IO-IO combinations? I would treat patients with sarcomatous features, patients with poor prognosis metastatic sites, patients with more than 1 metastatic site, Maybe patients with PD-1 positive tumors. I know we don't have enough information for this. And patients with rapidly progressive disease, which we know that it's very, very rare in the favorable risk population. I would not treat with IO combination patients with pancreatic mets, and maybe I would treat all other patients and consider individualized pros and cons. So my conclusions is IO-TKI combinations have shown increased progression-free survival and overall response rate, although not benefit in overall survival, and combination should be considered or offered in the most of the patients. So thank you very much for your.
Thanks, Christina. And now it's my pleasure to invite Nacho Duran to argue for, I assume, monotherapy.
Well, thank you, Samra, for the introduction. I'd like to thank the organizing committee for inviting me to be here today debating with Christina. It's an honor, and I'll try my best. So I have to defend, TKI monotherapy in good prognosis in favorable risk patients. So when I was preparing this presentation, I thought, okay, the key learning objectives is to reflect on current key goals when treating patients with IMDC, good prognosis, metastatic kidney cancer, and review the latest evidence about the potential benefits, but also the potential harm of IO-based therapies versus single-agent tyrosine kinase inhibitor. So let's start with the facts. And I've chosen to put a few pieces from Dali, who is from this region. It's about 2 hours north, but I thought it was a good opportunity, and each one has a little bit of a meaning. So this is something that is cleared, like that window that this lady is looking through. Dual therapy with either double immune checkpoint inhibitors or an IC plus a tyrosine kinase inhibitor has changed the treatment landscape for patients with advanced kidney cancer, and there is a significant improvement in overall survival for these patients. This is clear, no discussion about that, Christina. But why are we here debating today? Well, because as this picture of Salvador Dali, which is called Futile Efforts, I think we should know that while the overall survival benefits of the dual therapy over sunitinib have really been proven for patients with intermediate or poor prognosis, there is no such a good answer for those patients with favorable risk group. So I think this requires a debate. But let's look at this peaceful landscape, and I think this is how I see a patient with favorable risk according to IMDC. Is a patient normally with metachronous advanced disease, is a patient that normally has a good general situation with a good Kornosky performance status. There is no severe systemic repercussion of his or her cancer. This is mostly the case, normally no paraneoplastic syndromes, and probably, as Christina herself mentioned, asymptomatic. So it's quite a favorable scenario that we're confronting in the clinic. So probably, we should not forget what we know from previous studies, and this is the persistence of memory from Dali, that these patients really need kind of a detailed discussion before we make the decision about how to treat them. And there are a few options that we should consider. And observation and active surveillance is one of them, and there are studies that support this approach. The treatment of oligometastasis has been discussed today in a number of occasions. And why not a single-agent tyrosine kinase inhibitor, not a doublet? We've seen these curves, and I'm not an expert in statistics, but you can see the lines. Those lines do not really favor the experimental arm, and you can see some crossing of these curves. So these are the curves trying to demonstrate overall survival benefit for the patients of good prognosis in the 4 key studies. You could say, well, Nacho, you're using all data. Okay, let's go to the newest data, which is this curve from ASCO GU 2024. Dr. Hen helped me this morning, and he did a bit of an analysis of the meaning of these curves crossing and how that hazard ratio should be interpreted. So I think it's pretty clear in these curves that there is no demonstrated overall survival benefit, at least from a statistical standpoint. Okay, when we don't know about something, when we're not sure, we tend to gather all the available data and we do a meta-analysis, a systematic review. There are a number of them out there, excuse me for self-reference, but at least these 2 that we selected did not show benefit in overall survival for a patient with poor prognosis that were treated with a doublet. So this data has been shown before, and this picture of Dali is called the enigma of my wish, and I wonder whether or not this is wishful thinking. We would like to have biomarkers, and this has been commented again this morning, and Christina briefly mentioned it today, and maybe based on those biomarkers, we could choose what's the therapy that we should use for our patients. But unfortunately, there is no translation of these data to the clinic. We got studies ongoing that may help us, but still, this is what we have. So let me close with just 3 messages. So far, none of the first-line combination studies, either IO-IO or IO-TKI, have been able to formally demonstrate a statistically significant improvement in overall survival in the favorable risk patients with advanced kidney cancer. I think we should prioritize single-agent TKI in this patient population and only in selected cases consider the use of the combos. We need to keep on searching for biomarkers. We've been saying this for too long, I'm sorry, but we need to do this to help us guide in our treatment decision in metastatic kidney cancer. Thank you very much.
Thank you very much, Nacho and Christina, once more. If there are any questions from the audience, please come up to the mic. And I want to check also whether there are any questions from our current panelists, if anyone wants to jump in. Okay. Otherwise, I think I'd like to reprise... Danny, go ahead.
Hi there. That was a great debate. Favorable risk patients can be treated for a very long time. And I was just wondering, if you were to do a VEGF-IO combo, would it all stop at 2 years, or would you treat for 5 years or 10 years? Because it could be a very long time.
Christina, you want to go first?
That's the million-dollar question. And in fact, this question can be applied also for intermediate and poor risk patients. So I don't know, I think you can consider stopping treatment after complete response, after some time of treatment. If you follow the studies, you would maintain TKI forever, but we know that it's patients with good responses, maybe you shouldn't do that. So I would stop the TKI for sure. And the immunotherapy, it depends on the case. Many times I try to maintain it 2 years, but it depends.
I mean, just to add to that answer that I agree, this is one more uncertainty to add of the development of treatments in metastatic kidney cancer. Not all the studies were designed in the same way. We got studies that were designed until progression. We were studies that immunotherapy was given for 2 years and then stopped. But I would agree with Christina that probably when we have a patient in the clinic with a complete response, we got enough data to consider to discuss with the patient a stop and a close follow-up. I think I would support that too.
Thanks, Nacho. And just to echo what Danny said, the whole question about the escalation isn't just limited to this patient group, but across all risk settings. Go ahead, Martin.
Just as a quick comment to that extent also, we tend to talk about this duration of response and stopping therapy in the context of immune therapy, but I have several patients in my own practice who still date back to before IO therapy, and they were on TKI therapy for favorable risk disease for many years with me, and then stopped for a reason. They didn't want to stop, but then they had a heart attack or they had a surgery, and have now been off therapy for a long time, several of them for years without further growth. So I do think that to a very select group of patients, this question extends beyond just IO therapy.
Thanks for that. Michael?
I want to be a little bit more provocative here to all of you. Now what we see is that Danny Hang's wonderful criteria of describing the prognosis of patients are not really useful to choose a therapy for a patient up front. So we can use whatever we want. We just know the patient is going to be on therapy for so long, depending on the prognostic groups. I think we need to redefine criteria how to prospectively select therapies towards individual patients rather than using prognostic groups for that. We need to identify factors that actually allow us to choose which drug might be the best for the patient and not just look whether they're clinically fit or not, which basically is what Danny's prognostic criteria describe. I think we need to give up on the prognostic criteria for selecting patient and come up with something that's way smarter. And I hope we can find some of the criteria to select the patients better towards therapies. Because thinking from my standpoint, I don't want to be on a TKI for 10 years. And that's the overall survival that a first-line good risk patient can expect these days.
So I think we all agree that we can do better and build an IDMC criteria, but I wonder, given it was your session, Nacho and Christina, if either of you want to come in on that?
Sure. I mean, I wish we could do that kind of a study and give you that answer, which is very difficult or almost impossible, because, defining a predictive, marker so quickly, I think is hard. I had to oversimplify, Dan, the IMDC good risk patient, because that was my task, to defend. But I think it goes beyond just selecting patients that are well. I think those criteria that are based in thousands of patients, I think tell you something else. Probably in a few years, we will know better. I mean, there are some studies already pointing into that direction, that those patients who live for a long time, who have a better behavior, probably depend more on angiogenesis. We will end up probably putting better, let's say, little marks to these patients. But I think Dan's criteria deserves credit. Yeah.
Christina?
So yeah, I agree. I think IMDC it's not perfect. Sorry, Danny, but I think it's the best thing we have. But this is true. It is true that maybe sometimes you have in your clinics a patient. For example, I had like a couple of months ago a patient that was good prognosis, but he had liver mets, and we know that this patient is not going to do well with liver mets. So I think it's true. We need to improve, and we need to improve, especially from my point of view, in the molecular environment.
Thanks, Christina. So something for us as a group to take on as a challenge in the years to come.
So thank you very much. So now we're going to move to the third debate. Having agreed that we're not quite sure what is the ideal therapy in our patient populations, and that there's a thorny question about patient selection and trial design, we now have asked both Bernard and Martin to talk to us about their thoughts. What should be the control arm in future clinical trial design in the first-line setting? So Bernard, thank you.
So, good afternoon, and thank you for asking me to answer this difficult question. So, you're going to be disappointing. I'm not going to give you the good comparator arm, but I'm going to give you what we should not do, I think, as investigator, and then I'm sure Martin will give you the comparator arm. So the idea behind my talk is to provide insight on what should be avoided when you do studies, and understand how this could influence randomized trial strategies. So I think some comparators are unacceptable, and I think we should go back to some trials we have done and which maybe we should not have done. And this is one typical trial that I think was not selecting the good comparator arm, which is an old temsirolimus arm. At that point, we did temsirolimus versus combination of temsirolimus of interferon and interferon alone. And interferon was considered as a control arm when we had shown in France in our group that cytokines should not be used in poor risk patients, which was the topic of this study. And even in addition to that, we had shown that progesterone acetate was as good as cytokines in intermediate risk patients here. So I think we should not use one of these comparators, which in our idea is not acceptable because not good enough in terms of comparator here. Another comparator, which is, for me, unacceptable, is to use a placebo when we have an active drug available here. And this is typically one of the studies which was difficult to support at that time, which was presented by Korastenberg some years ago. And I remember during our presentation, one of the patients raised up and said, why did you accept to do this trial here? And I think we should not use a control arm which is not acceptable as in terms of ethics, even though it's done in countries where drugs are not available here. We should also not use control arms when we have better control arm here. And I think when you look at the 9-year study, we have used sunitinib as control arm. I think it should not have been accepted at that time here when we had shown years earlier here that nivo-EP was much better than sunitinib. And we launched 9ER still using sunitinib as control arm. And I think we should not have done that. Even though, I mean, the study was positive, I think it should not have been accepted to use sunitinib as control arm in this 9ER study. It was done neither, and some of us, including me, did participate into the study here. We should also take into account new information that we had. And if you remember, in all the study using sunitinib as control arm, I mean, sunitinib 2-1 schedule, which has been shown by different groups as better than 4-2 schedule, was not allowed to be used in the studies. I think this is once again not acceptable, and I think as investigators we should not accept that company impose us not to use the best schedule we have in our hand actually. We should also discuss about using the best comparator. And Laurence presented this study, update of this study of belzutifan versus everolimus, which was a positive study here. But why did we choose everolimus when we had tivozanib, which has been presented earlier in the TIVO3 study, showing that it was a better drug to be used here? I don't know whether belzutifan would have been positive if we had used tivozanib as control arm here. Finally, I think we should not, we can use a good comparator, but we should use also the best endpoint here. And this is a typical study where I think, I mean, we were wrong. I mean, the comparator was good. I mean, the COSMIC study used nivo-EP as control arm, which is perfect. I think nivo-EP versus nivo-EP cabo is, for me, the best study to do. But why did we use PFS as a primary endpoint? Just adding cabo, we knew that PFS would be better here. And I think having PFS benefit by just using a drug, which we know is going to increase PFS, was not for me the acceptable endpoint, and I think this should not have been done with PFS as primary endpoint here. So my take-home message for all of us. What does mean this for the future of care? We, as academic investigators, have the responsibility in accepting being part of inadequate trials. We should ask the question in our mind, should we be part of a study where the control arm is not acceptable? And I must say that I have been part of them, and I think as academic doctors, we should have the responsibility to say no. Second question, the health authorities have policies different from best academic research, and maybe we should influence health authorities to change their mind. Thank you very much.
So now I'd like to invite Martin Voss to tie this all up for us and maybe give some illustrations about what comparator arm we might use. Martin.
Sure, here. Okay, thanks very much. So thank you for inviting me to this very interesting session. It's very difficult to follow Bernard on any of these things, but he set the stage very nicely, as have all others. So we don't have, you know, this black and white debate where we were asked to debate at one point or another, he and I, and we talked a little bit, and we thought it might be helpful if he pointed to some deficiencies, and then I proposed some suggestions for trial designs. And the learning objectives, you know, are very similar to all of what we have heard. You know, there's shifts in treatment paradigms, and we have to think through the best standards that we have currently, how these are continuing to evolve, and how they might inform comparator arms in randomized clinical trials. And of course, eligibility criteria for trials are what shape the study population, and they should determine what the best comparator should be. And Bernard has told us that the comparator must be acceptable to the treating physicians and, of course, the patients ultimately. So they must best reflect contemporary treatment strategies. Now, often the difficulty is, of course, that by the time a phase 3 study is written, put together, rolled out, and analyzed, those standards have changed. And it is an evolving treatment paradigm. And just thinking through the session that we've had and how this is currently in front of us, of course, you know, we think about frontline treatment by ways of IMDC, and it's Checkmate 214 that has put us into this position, and it's been helpful in some ways and very difficult in others. But if you look through society guidelines, through our debates that we have here throughout all of these sessions, and through your own thinking in clinic, IMDC is very much a part of that. And now it just got a little bit more complicated because we, threw an adjuvant option in the mix. So now there are so-called first-line patients who really are not first-line anymore because they've been pre-exposed to adjuvant therapy. And that is a question we're increasingly going to ask ourselves, and it essentially has created a new clinical trial setting for us that needs to be studied. So technically, you could think through this as 3 different settings here, and I'm going to try to walk through all of them. And at the end, I'm also going to, conclude that maybe IMDC is not the best way to think through this. So if first we think through this quasi-first-line setting after exposure to adjuvant pembrolizumab, then think about how you approach this in clinic. Now, we've been asked this question on the podium a couple of times over the last year or two, and most of us would say it depends a little bit on the amount of exposure and the timing of progression. And what I mean by that is if someone comes to me in clinic who was treated with adjuvant pembro and they progressed while on that therapy, or they progressed shortly thereafter, and you can think through the pharmacokinetics and receptor occupancy, half-lives, and things like that, and most of us would have a time frame in mind, then maybe that patient is not well served to continue PD-1 strategy in a combination. In the metastatic setting, CONTACT-3 has taught us that keeping the PD-L1 backbone on as someone progresses on a PD-1 containing combination is not what it intuitively once was. There are patients who have more harm, and there doesn't seem to be benefit on a population basis. Now we have TiNivo-2 coming, so maybe there'll be new information, but as it stands today, I would argue a patient like that on a clinical trial could be randomized to cabozantinib monotherapy or another TKI, which is what we often use in the second line after IO-containing regimens. Now, someone who's further out from receiving the last dose of pembrolizumab, meaning they've had adequate exposure, I would say at least 2 doses, and they've now progressed, and it's been a while after they completed their treatment, I think is in a benefit of the doubt type situation. Those patients in my practice now, I would offer TKI IO-containing regimens in the first line. So I would argue if we designed a clinical trial in that setting, then a good combination comparator would be IO-TKI. In part also knowing that in IO pretreated patient, CTLA-4 inhibition may not be as efficient as in someone who's never been IO pre-exposed. And we know that from studies like Omnivore, Fraction, and so forth. The IMDC intermediate poor risk setting is probably the easiest one because there we have general agreement that these patients now in clinics should be treated with an IO-containing doublet. So you could write a trial that mechanistically, you want to add on to an IO backbone like COSMIC-313, or you could think of something that, goes more along an IO-TKI line. But I think the sense that all of us would have, these are patients who should be compared to an IO doublet, and the primary overall endpoint for that should be overall survival. It's the least controversial setting in my mind to think about trial design. And favorable risk is really where it gets very, very difficult. I mean, we just had that debate, and I thought it was very helpful to have that right ahead of my talk here, right? So there are arguments that can be made for TKI monotherapy and for IO-TKI, and that's because these patients are very heterogeneous. In my own experience, I see more of these patients being treated with combinations, and I think that's because oncologists, see value in added PFS and an added response rate, and it's important to patients also. But others would argue, well, we might be over-treating patients. I don't see anyone who has the favorable risk debate and wants to be more aggressive than TKI-IO. So what I would propose, one could say is, well, if you had IO-TKI as a comparator in the favorable risk setting, then the novel treatment that you're studying is something that should be tolerable and maybe expose the patient to less therapy, which goes back to many of the things that we discussed in the past section. We treat these patients now with up to 2 years of IO, and then we keep the TKI on. So maybe that should be the comparator arm. And then, the novel regimen, whatever it may be, should speak to a shorter total duration of disease, or maybe mandate that everyone stops once they achieve a deep response, a CR, however you want to define it. And maybe we should think about other endpoints. Maybe for this, then, PFS non-inferiority would be an acceptable endpoint. Now, you could argue that the only PFS non-inferiority trial that's been done in RCC has been COMPARES. There was a 1,200-patient trial in all comers. So to get enough events and the study size and the duration of treatment to do that in only favorable risk disease is impracticable, but that's not part of this debate. And then back to points that many have made here, we use IMD risk stratification as I think a useful tool, but it has many limitations, and it's a very crude estimate of biology. And there's different ways to show it. We looked at the Motion 151 plots from the Cancer Cell paper that everyone knows well, and this is a similar transcriptomic analysis we've done in the past, where you see, sure, the medians of where these patients plot are different, but there's so much variability within the favorable risk group that you can't really say, oh, these must be angiogenesis rich always. So pie in the sky, big dreams. If we had a new regimen with a solid molecular rationale and a molecular biomarker that we wanted to test, how would the comparator look? I would argue that a trial like that should be randomized to IO-TKI, which in present day is sort of the all-comers approach, favorable, intermediate, poor risk, and we would randomize here the novel regimen with a molecular rationale that selects these patients to the patients with these criteria who are now being treated IO-TKI. And I do think that a design like that should allow for crossover thereafter, and with that the endpoint should be PFS. And that might be a phase 2 study, might not be so big a trial, but I think it would move the field forward to think about that. And lastly, because we should talk about that, for the non-clear population, going back to the session we had before, if one were to do a randomized trial, and I had a say in it, I think based on the B61 data, IO-TKI should be the comparator arm for papillary RCC, be it lenvatinib, pembrolizumab, or another combination. So I'm over time. I'll leave you with the take-home messages here. Thanks very much, and looking forward to the discussion.
Thank you ever so much. We are just ever so slightly over time, but if there is one short and pressing question from the audience, I would take that. And if there isn't, I will... Oh, Laurence.
Yeah, so along the line of patient selection criteria, there is the OPTIC study that Brian Rini is currently running, which has an endpoint of response rate. And my question is to the panel, but it could be to anyone here, is do you feel that response rate and the demonstration of the rationale that we're able to basically use a biomarker in routine is enough to influence your strategy, or you would like to see randomized data there?
So I'm happy to take that. So I do think it was a good choice in this case. I think that trial is ahead of its time, and I think it deserves a strategy that provides us with an answer sooner rather than later that can inform future trials. I don't think anyone, including the folks who designed that trial, is out there to try to once and for all in one swift strike change the standard of care. But I think they're changing the way that we're doing trials, and I congratulate them for doing that.
So final quick question.
It's not a question, but it's something that we need to draw our attention to. I'm Birdie. I'm a patient advocate from Germany. And we always have to take the strongest competitor because of HTA processes in some countries where we don't get a reimbursement for a new treatment because it's compared to a weak competitor. And we've seen that in breast cancer. So please, we have to be aware of that. And if you are approached with a trial with a weak comparator, we have to say no. That's what I think. And this is where, because otherwise we don't get it reimbursed and we don't have a new treatment. And that would be poor for us.
So, thank you so much for making that point so clearly and backing up what Bernard was saying to us earlier. And maybe that's a perfect note on which to draw this session to a close. So I would like to thank all the speakers for sharing their thoughts and wisdom and engaging in the debate. And with that, we'll hand over to the next session. Thank you very much indeed.